This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now, if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to go over static manual release of the splenius muscles. That's the Splenius Cervicis and the Splenius Capitis. I'm going to have my friend Melissa come out. She's going to help me demonstrate. Now, we're going to use the same four-step process we've done in other static manual release videos. We're going to talk about how to palpate and differentiate the splenius from the other structures proximal to it on the posterior lateral neck. We're going to talk about any structures that might be proximal to the splenius muscles that we could insult or abrade with compression. We need to talk about trigger points a little bit because that'll help the efficacy and accuracy of this technique. And then we're going to talk about client and practitioner positioning so that I'm in a position that I can comfortably hold this technique and my client can relax in the position they're in so that we can actually get a release. Now, step number one of this technique is by far the hardest. It helps to know a little bit of functional anatomy. We have to figure out how we're going to differentiate the splenius from the upper trapezius and the levator scapulae, which it lies in between. Now, it is important to be able to differentiate this structure because the upper trap, splenius, and levator scapulae don't all rotate the head in the same direction. So for example, if I assessed Melissa, she came in with some cervical dysfunction, maybe even some cervicogenic headache, and I noticed that she could not rotate her head completely in this direction, I need to know which of those muscles I should release on this side and which I should release on this side. So let's talk about functional anatomy a little bit. My splenius, and this is Splenius Cervicis and Splenius Capitis together, originate from the spinous process of T6 up through the ligamentum nuchae to the spinous process of C3, and then they kind of run off in this direction, all right, so from inferior medial to superior lateral towards the mastoid process of the temporal bone. And you guys can feel that little bump that's behind your ear, that little point, right? That's where these fibers are heading to. You can imagine if I'm on this diagonal that when these muscles shorten, they'll create ipsilateral rotation. So the rotation the splenius muscles create matches the levator scapulae, but opposes the upper trapezius, which rotates this way. So, for example, if I had Melissa here and she had great rotation this way, but couldn't rotate this way very well. Let's say she's stuck right there. What I would probably want to do is release levator scapulae and splenius on this side, but upper trap and deep extensors of the neck on this side. The more accurate I can be, the better chance I have of getting good outcomes. So how do I get to this structure? Well, we need to skip to step 3 real quick. Knowing where the common trigger points are, where we're likely to find those increases in tissue density, is going to help. So trigger points are commonly just in line with the C7 spinous process, which is usually that most prominent spinous process at the base of the neck. So you guys can look for that and think, okay, I got one trigger point that's going to be in here somewhere, and then the other one just happens to be in line with C2, which is the first spinous process I can feel underneath the head. It's nice and convenient, so at least we have two nice landmarks we can kind of line up with. Now, although I said that this trigger point here, which happens to be the trigger point for the Splenius Cervicis, is in line with the spinous process of C7, I can't just go, that's not going to work. Might leave a nice bruise, but I'm probably not going to get to the splenius muscles. I actually need to get deep to the upper trap, and the only way I can do that is by finding the anterior border of the upper trap and falling off this way. So I don't know if you guys can kind of see my finger there fall off in front of the trap. Now we have to take another step here and get a little bit more technical and find the laminar trough, which is the trough between the transverse process and the spinous process here, right? So between the spinous process and the transverse process of a vertebrae, you have this little divot. You guys can even kind of feel that if you kind of palpate into the neck here. The only difference is we need to find this trough while anterior to the trap and heading down towards C7 spinous process. You guys got that? So anterior to the trap, into the laminar trough, towards C7 spinous process, and then we hit the levator scapulae. Darn it. Okay, we're almost there. So what we're going to do is we're going to laterally flex. That's going to help soften up the upper trap a little bit, and then we're going to ipsilaterally rotate. And although this is going to shorten our tissues a little bit for the Splenius Cervicis here, it's going to allow me to get my thumb in between the upper trap and the levator scapulae, which is just anterior, into that trough so that I can start doing my short stroke strumming perpendicular to the splenius fibers, which, remember, these fibers go up this way, so I'm actually going to be kind of doing these tiny little strums out this way in the trough, right, with her head in this position until I find the most dense fascicles. I'm going to look for a nice nodule once I find those fascicles, and it's right there. All right, and then I can use her head if I need to add a little tension, right, to kind of stabilize that nodule so I'm not playing the finger on top of the marble game. I can do that here. Now the other trigger point, which is going to be our Splenius Capitis trigger point, all I need to do is start searching in through here and look for fibers that are heading from the spinous process out towards this mastoid process. Right? The splenius muscles have a unique fiber direction, which is kind of what I mentioned before, is why we need to be able to differentiate these tissues. They rotate differently than the deep extensors of the cervical spine underneath them. So I can have Melissa do all sorts of things to help with my palpation, right? Like I can kind of get my fingers in the right place, and then I can go, hey, do you mind rotating towards me against my thumb? Right? And then extend your head and turn it laterally towards me. Right? And then if I do my short strokes here, right? So I'm going to come down this way. I can kind of see, all right, so I got her contracting the right muscles. Can I get them? Can I feel the ones that are going in the right direction, heading in the right direction? And I can actually right here. And then once I find those tight fascicles, is there any nodule or point of acute density that I can press on? Now, a couple little things here, guys. Take your time. This isn't a race. Nobody's expecting you to just put your finger right down on a trigger point in a muscle that's fairly deep and hard to palpate. Like, that doesn't show proficiency to just kind of go, It shows maybe carelessness more than anything else. Your patient doesn't know whether this should take you 15 seconds to find or 3 minutes to find. So if you know your functional anatomy, you can think of those fiber directions. You need to move your client's head around a little bit. You need to have them contract the muscle. That's all fine. That's all fine. Take your time. I'd rather you took 3 minutes to find the right point than to spend 15 seconds and be totally wrong and not get any outcomes whatsoever. Now, although we don't have too much issue here with sensitive structures, as long as you don't jab your finger up in towards the occiput, that you kind of stay going posterior to anterior, you shouldn't run into any structures that are particularly sensitive to compression. You do have to be a little careful with the Splenius Cervicis point, because if you press down real hard, real fast, and you're not real careful, you could stretch the brachial plexus. So if you get any burning, searing, tingling, they get that little jolt, right? They get any numbness or funky pins and needles in their fingers, guys, move, take your time, Move your fingers around, get off the brachial plexus, see if you can mess around with some ipsilateral flexion to get that brachial plexus out of the way and still get to the muscle you're looking for. Now last, we do need to talk a little bit about patient and client position. This is not a good idea, right? This is kind of weird. Right? I'm not just like palming people's foreheads and jabbing my thumbs in places where I can't see, especially because I can't see this trigger point here. This is all for you guys to be able to see a little bit of the anatomy and how my hands are placed relative to some other structures. If I was going to do this in a seated position, which you can, I would have Melissa swing her legs over the end of the table here, and I would come sideways, and then I would probably use that kind of quasi headlock position. I'd drop the table down here a little bit. But we talked about putting the forehead in the crease of your elbow in another one of our manual release techniques for the neck. Right? If I do this, I can now move her head comfortably and she feels nice and stable. I can use my body against her shoulder, right? Like my rib cage and my torso here a little bit. And then I can take this thumb and get right where I need to get. This particular technique doesn't take a whole lot of pressure, so you might be okay. It's not ideal body mechanics. I can't really get my forearm perpendicular to or parallel to the direction of force, but we're close to good position here. I personally prefer to do this in supine, so I'm gonna have Melissa swing all the way around here. I think supine is much more comfortable for both the patient and the client, and I think you guys will agree. If I just slip this hand underneath the occiput, I now have total control of her head. And Melissa's very relaxed right now because we've done a lot of these videos and she trusts me. Poor thing. She has had her neck worked on with me before. It might take a second to get your patients to completely relax, but you do have really nice control this way. And then I can take this hand and I'm going to use kind of this technique of reaching underneath her neck, and I can see her trap right here, drop my hand in right anterior to it. I'm going towards that laminar trough, and since I can feel C7 with these fingers, right, I can drop my thumb right down in that direction, move her head however I need to. I can start doing my strumming out perpendicular to those fibers, find the tightest fascicles, find my tight nodule, add a little tension so that I'm nice, so that I have that nodule pinned, and then wait for a release. And believe it or not, the Splenius Capitis trigger point is even easier because all I have to do is move my fingers like this, right? So I leave these digits kind of facing up, and I'm just going to use the weight of her head, right? I'm going to find C2, which is that first spinous process I feel underneath her occiput. I'm going to look for the fibers that go in the right direction, and I might have her like, okay, can you rotate into this side here? All right, I might have her rotate a little bit and then try to strum those fibers, find the most dense fibers, find the most dense nodule, and then once again, just have her totally relax. The nice thing here is like my hand is curled, and then I just have the weight of her head hold for me until we get a release. Stay tuned for the close-up recap. So now for our close-up recap of the Splenius static manual release. We're starting here with the Splenius Cervicis manual release. You can see my thumb is actually just anterior to the anterior border of the upper trap here, and that my hand is wrapped underneath. I'm going to fall off the anterior border down into the laminar trough, which is the space between the transverse process and the spinous process on the posterior aspect of the cervical spine. I know that my common trigger point is down near the C7 spinous process, so I can even palpate the C7 spinous process with these two fingers and give myself an idea of where that is, and then kind of push my fingers towards one another. But unfortunately, the first thing I run into actually is my levator scapulae. So the way I get my levator scapulae out of the way is I do a little ipsilateral rotation, and although this takes some tension off my Splenius cervicis, it's the only way for me to sink my finger down between my upper trap and levator scapulae. Once I've sunk my finger down in there, I can then use my short strokes, kind of this lateral to medial stroke. And these are very short strokes, guys, just a couple fascicles at a time, to find anything to me that feels overactive, feels tauter than it should be. And then once I find those taut fascicles, I can kind of move inferior to superior or superior to inferior to try to find the densest nodule. And then I can actually, once I've located that nodule, go back into a little contralateral rotation, contralateral flexion to add some tension back in those tissues and help me pin that point of hyperactivity. Once I get a release, of course I can move on, and of course this is the more complicated of the two release techniques for your spleniae muscles. The Splenius Capitis muscle has a trigger point that's commonly at the level of your C2 spinous process, which your C2 spinous process is the first spinous process you feel underneath the occiput, so that's fairly simple. And we know that the spleniae have this kind of unique fiber arrangement that's this way. So all we have to do is kind of go just to the side of C2 spinous process here and look for fiber direction this way. Find our tightest fascicles by strumming this way, right? Kind of from in the same direction that her shoulder to her ear would be, right? So we're strumming perpendicular to those fibers. Once we find them, find the tightest fibers that is, we can kind of go lateral to medial to see if there's a nodule or point of hyperactivity. And then I'm just using that kind of curved hand position and the weight of her head to do all the work. And once I get a release, we're good to go, and I would reassess. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, one-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.